Mr. Bilirakis, you're on.
Yeah, thank you, Madam Chair. Can you hear me? Can you hear me?
Yes, we
Okay.
can.
All right, very
Yes.
good. Thank you. Thanks for, again, Chairwoman Ashu for scheduling this hearing. I think the participants, they've done an outstanding job. I do want to see us, and we may have done this in the past, just a suggestion, having a demonstration available to us with regard to behavioral health, telehealth services, but also primary care services. I've done it in my district, and I encourage other members to, and I'm a strong supporter. We've seen throughout this pandemic that telehealth services have provided a critical lifeline for millions of Americans, especially seniors, allowing them to receive quality medical and behavioral health care from the comfort and safety of their homes. They're more comfortable. They really are. As we build on the successes of the previous administration's response to COVID-19 and look beyond, we must ensure patients, especially our seniors and those managing chronic conditions, are able to confidently access the appropriate care they need. Patients and their providers should also be empowered with more, not less, options to capture health statuses accurately, safely, and conveniently. I have a question here for Mr. Riccardi and Dr. Marotra. As a staunch supporter of the Medicare Advantage program, and most of us are, I was pleased to see CMS provide much needed flexibility to allow healthcare providers to offer telehealth services under the Medicare Advantage plans. However, CMS guidance requires that these services include a video component, which is not an option for some patients. And I know some of our members have expressed concern about that. Low income and rural patients, for example, may have trouble accessing technology or broadband services supporting video communications. Additionally, seniors or frail populations may have physical limitations that prevent them from using video communications, and that's true. For these patients, an audio only telehealth visit may be the only option. Again, as our witnesses have stated, may be the only option besides delaying uh, needed health care, and we don't want that. On August 3rd, 2021, CMS updated the risk adjustment telehealth policy for ACA plans to allow for reimbursement for audio only visits for purposes of risk adjustment. However, the same has not yet been extended to Medicare Advantage plans, even though the same audio only services are being provided by the same clinicians using the same coding guidance. Are there any, and this is a question, are there any ongoing concerns that you are aware of with programmatic fraud that may merit differences between the two programs, or should certain guardrails be put into place if such policy was extended to Medicare Advantage plans? And if so, what should those guardrails be? Again, the question is for Mr. Riccardi and Dr. Marotra.
Thank you for your question. I have just three quick points that I would like to share. First, we support the flexibilities for telehealth in the Medicare Advantage program, and also through the demonstration projects and the alternative payment models. It's crucial that the expansion of telehealth benefits, such as the geographic site, removing those restrictions, it's really essential that it's also applied to fee-for-service original Medicare, because we could potentially leave behind millions of people who've been using these services, and where this innovation has truly occurred over the last several months. In respect to the barriers that people face using technology, that's correct. People may have compromised immune systems, physical disabilities, an inability to leave the home, lack of transportation. So telehealth really is essential across the program coverage options that people use to access their services. And so in respect to program integrity, fraud is always a concern, and utilization, but we recommend removing barriers to access and then using data and information on the back end to kind of detect any potential fraud, waste, or abuse. And audio only clearly, has a role in the helping people, in particular with behavioral health issues, access the services that they need. So it should be considered.
Very good. Thank you, Doctor.
Yeah, 2 points. On the risk adjustment aspect, Representative Billrockis, I don't know the details behind that, but I do think that if those visits have diagnoses that should go into the risk adjustment algorithm, it seems reasonable to me. But more to your point about the audio-only telemedicine visits, I think, and the Medicare Advantage program, I think I would emphasize that if we look at both private insurers and those in the Medicare Advantage plan, who obviously have to worry about overall spending, they are also very judiciously moving forward here. And I think their experience should also give us a lesson because they are concerned about the same issues. And to my knowledge, most are not planning on covering audio-only telemedicine visits in the future. And so I think that should be, a lesson to all of us as we think about the Medicare fee-for-service program also.
All right, thank you very much. Madam Chair, for inclusion, I provide this committee with a copy of a letter of support for a bipartisan bill I plan to soon reintroduce called the Ensuring Parity and Medicare Advantage for Audio-Only Telehealth Act, which includes guardrails to prevent potential Medicare fraud and abuse by ensuring patients have an established provider or practice relationship where audio-only diagnosis is being utilized and that diagnosis were previously documented in person. I think it's so important. So I'd like to admit this into the record, please.
Did you just read the letter to us?
Yes.
So ordered.
Thank you so much.
Make it part of the record.
Yeah, I've got a couple more questions, but I'm not going to go into them. But I will tell you this, and I've got 30 seconds. I remember years ago, we did one of these field hearings in Pennsylvania, rural Pennsylvania, and I was really impressed because the patient actually came to the hospital and was treated, or maybe it was a clinic, was treated for primary care. However, a specialist was needed, and then the telemedicine, the telehealth was done from Philadelphia, I believe, and the specialist was able to speak with the primary care physician and the patient, and I thought that was a great idea. So I think that that's being done quite a bit. But anyway, my time has expired, and I appreciate it very much. Thank you.
Thank you, Mr. Bilirakis. I remember many years ago,